Who in this room has seen Game of Thrones? Glenn? Yeah, good. All right, so we always start with the case, right? So a 40-year-old man is injured while hunting wild boars. Who's that guy?
Baratheon.
Good, Robert Baratheon, right? So giving you all that you know, what type of shock is he going to suffer from?
Hypovolemic.
Hypovolemic, good.
Just trauma.
Yes. Good, yes.
But a real fan.
We can make up.
I'm not ready for that.
But a real fan will know that it's going to be hypovolemic, right? So actually, there was an article, this is a great article, called Death is Certain, the Time is Not, Mortality and Survival in Game of Thrones. So I found this article and it is amazing because it's these two guys, okay, Rydar and Benjamin. Rydar sounds like, a member of the character. Who went through every show and pulled out all the deaths and ranked them. Was this a highborn, a lowborn character? What house were they from? Were they named or not? How long had they been on the show before they died? What did they die of? And then they did some statistical analysis and reported all this information. So causes of death of notable characters in Westeros, right? So you see this list here, but it actually turns out to be 99.7% of them die of hypovolemic shock. Right? Now,
Kaplan Meier curve, like
as an aside, I pulled this up. I was talking to some medical students about this, and they were like, "That's interesting." They were like, "But that seems so random. Why would this be?" So they went online. They realized that injury epidemiology is one of those sort of throwaway journals that you have to pay $3,000 to publish in. You know those? You know that you could pay a lot more to publish in, which I think elevates this even more because these guys love this so much that they're like, not only going to watch every episode, write down every day, all the details every day, but then we're going to take $3,000 of our own money and publish this.
Yeah.
So it's pretty cool. So as you know, in our realm, we do not have 99.7% hypovolemic shock. Actually, we have a much less percentage, so 16% of hypovolemic shock, right? You guys know the four causes of shock: hypovolemic, cardiogenic, obstructive, and distributive. And as you know, distributive shock is the largest, and within distributive shock is septic, right? So very often in our ICU, we sit around and talk about the patient who's in shock. Every patient who's on pressors is in shock, right? I don't think we do enough to really say formally, okay, these are the four possible causes of shock, and why are we ruling in or out some of them? So we often will try and take a step back and sort of think through what's happening with each patient, even though most of the time it's going to be distributed, it's going to be septic, it's going to be something of that sort. We do want to try and rule that out. So there's ways to do that, and we'll talk about that as well. So the first is definition of shock, right? So circulatory failure resulting in inadequate perfusion of vital tissues, inadequate cellular oxygen utilization. So this is on a cellular level, right? Circulatory failure, it has nothing to do with blood pressure, right? So although we follow blood pressure as a surrogate marker, patients who have very high blood pressure and then their blood pressure is low, but still in a normal range, might have poor cellular perfusion, right? So they might be in shock even though their MAP is 7, right? Diagnosis is clinical, hemodynamic, and biochemical. Again, not blood pressure, right? So apparent through 3 windows in the body, and all these little cartoons and graphics are from a shock article in the New Journal. Mental status is cloudy, skin is cold and clammy, urine output is decreased. So you can be at the bedside, review what's going on, right? And the effects of inadequate perfusion and oxygen deprivation are initially reversible, but rapidly become irreversible. And this concept of the 4 types of shock, all leading to sort of a final common pathway of shock, is an important component, particularly in the way that it's studied. Sequential cell death, end organ damage, multi-organ failure leading to death. It's not a good thing, right? And so this is why we want to figure it out early, try and resuscitate as quickly as possible so that we can avoid this progressive and irreversible shock. Clinical scenario, physical exams, labs, and imaging. Consider right heart catheter to talk about, as well as critical care echo. So clinical scenario, right? So 56-year-old male motorcycle accident victim, what type of shock? 75-year-old male with a history of myocardial infarction. Good. 23-year-old female with a history of OCP, use and smoking. Yeah. 12-year-old boy with a history of peanut allergy. And 20-year-old female male with fever and pneumonia. Good, right? So it's very simple when you think about it like that, right? The clinical scenario is really going to point in the right direction. Diagnosis is key to treatment, though, right? As we talked about, obviously, right? You're not going to give you're not necessarily going to treat cardiogenic shock in the same way you're going to treat hypovolemic shock. This is the PA catheter. You probably have never seen this before because it's very rarely used now. It was used a lot. It was kind of fallen out of favor when I was a resident, actually, even a medical student. But it is it's a really long yellow catheter, right? It is inserted all the way in, and it actually comes all the way down through the right atrium, through the right ventricle, up into the PA, and then out into the PA as well. Swan and Gans are the guys who came up with PA catheter. It's actually pretty cool what they figured out how to do. They were supposedly sitting at the beach, trying to come up with how to float things through the circulatory system. Saw the sailboat go by, thought about maybe creating some sort of sail, which led to this inflatable balloon at the end of the PA catheter that would then float through. Like any good doctor, they tried it on themselves first, right? And so they were able to float the PA catheter into themselves before they then brought it out. All right, so it helps to diagnose and monitor treatment. So this is just a picture here that shows where the PA catheter goes. Right atrium, right ventricle, up into the PA here, and then out into the capillary bed to quote unquote wedge, right? And this is the waveform that can be seen on the monitor as this is performed. It gives you a lot of information, right? So the wedge pressure is an estimate of the left atrial pressure, and therefore LV preload, right? LV end diastolic pressure. Cardiac output is measured, sort of gives you that sense of pump function. You can measure afterload and systemic vascular resistance, and then the mixed venous oxyhemoglobin saturation, giving you a sense of tissue perfusion. This is your up-to-date table of the findings of different PA catheter hemodynamic profiles and what type of shock is present. We'll go through each of these individually. This is good and bad. I find this to be somewhat of a complicated table because they have early and late stages. And I think it just speaks to the fact that some of this information is difficult to interpret, which probably influences the use or lack of use of the PA catheter in undifferentiated shock, right? That study showed that you give multiple different smart docs the same numbers, and they will come to different conclusions about what's going on with the patient. All right, but what we can do nowadays, and what I encourage everyone to do, is anyone who has undifferentiated shock should get an echocardiogram, right? And that should be done by us at the bedside, right? So the sort of quote unquote critical care ultrasound, critical care echo. Not as intensive as a cardiologist might perform a echocardiogram, not with all of the measurements, not with all of the cool machines and different devices that you use, but just enough to answer your clinical question, right? Why is this person in shock? So distributive is going to look sort of normal with preserved contractility often. Hypovolemic, small chambers and normal or high contractility. Cardiogenic, large ventricles and poor contractility. And obstructive pericardial effusion would be for tamponade, or dilated RV would be for PE or pneumothorax. So looking at this, so cardiogenic, that's going to be obvious, right? The heart's just not going to be pumping as well as pump failure, right? You're going to see very dilated, low EF. Obstructive, if you see a big pericardial effusion, that's a concern, right? Dilated RV and elevated right-sided pressures, also a concern. Hypovolemic and distributive are going to look very similar sometimes, right? Because distributive is sort of a hypovolemic type state, secondary to dilation of the systemic vascular resistance. So a shock echo might not give you the absolute answer, but it will rule out some other types of shock. So obstructive shock here, you see this bowing of the RV free wall here and this is during early diastole, okay? Showing that there's an increased amount of pressure from the pericardial effusion here. This is for obviously pericardial effusion or pericardial tamponade. On this side is where you have a very large RA and RV and actually pushing against the intraventricular septum here. So that would be consistent with a large PE or pneumothorax. You can see how if you push up against the intraventricular septum to this extent, it's really going to impede the EF and therefore cardiac output, which is what's causing the shock in this case. Cardiogenic shock, large LA and R and LV here. You can see that very thin walls here. And then hypovolemic plus minus treated. As I said, they kind of go together a little bit. So in this case, you see a lack of collapse in the IVC here when looking at the IVC in the subcostal view. That's going to argue that there's an increased right-sided pressure and or there's volume. If this is very much collapsed, then there's potential that there's a low volume state, whether that be secondary distributed and dilated capillary beds or hypovolemic. Good. All right. So a 40-year-old man is injured while hunting boars, but he smoked, drank, had high blood pressure, presented with chest pain. So what type of shock would this be? Cardiogenic. Good. Excellent. All right. So 300,000 ST elevation MIs per year in the U.S. Shock occurs in approximately 9% of them. This is a list of the causes of cardiogenic shock. It's not just MI. Obviously, the chronic heart disease, acute myocarditis, NSAID cardiomyopathy, as I mentioned, advanced valvular disease, and then cardiac arrhythmias will develop. This is from that table again, right? So if you have cardiogenic shock, you're going to have primary pump failure, right? And then what's the compensatory mechanism? So the primary is going to be pump, cardiac output goes down. The compensatory mechanism is a substantial increase in systemic vascular resistance, right? Because of that, you're going to see an increase in the pulmonary capillary wedge pressure. And the mixed venous oxyhemoglobin saturation is going to be low. Blood is flowing slowly through. There's not enough cardiac output to facilitate appropriate oxygen utilization in the periphery, and you're going to take more oxygen out of the blood than you otherwise would. So this is a great graph with regards to sort of the warm, cold, warm, wet, cold, dry, cold, wet state, right? And it's cool because you have a cardiac output on the y-axis here, and as cardiac output decreases, right, you go from sort of a warm, perfused state to a cold state, right? So that's why you feel the periphery, extremities. At the same time, as the pulmonary arterial occlusion pressure or wedge pressure increases, you go from a dry state to a wet state, if you will. So pulmonary edema will start to develop. So you can plot this and see where patients are on this scale. Also warm and dry is good, right? And cold and wet is bad. So depending on where you are in that state, you can treat. Certainly if there's cold, you want to augment inotropic, you want to provide inotropic support, augment cardiac output. If the patient is wet, you want to try and dry them out. How do you treat it? So you try and give the heart more squeeze. So give inotropic support, diurese, maybe potentially do something like a controller. Case 2. A young man at his wedding is exposed to something causing trouble breathing, tightness in the throat, and hives. Look at it. Good. Distributed shock, anaphylactic, right? Who's this guy?
Joffrey.
Good. He did seem like he kind of died from anaphylactic shock, right?
Good.
I mean, it was some sort of poison, but his face did change of color, but I'm not sure his sinus is normal. Well, it was like that dilation of the vessels as well. So systemic so distributive shock we know is actually different than the other three because the primary issue is an issue with the systemic vascular resistance. You get peripheral dilation. And because of that, your compensation is an increase in cardiac output, right? Whereas the other three are going to be primarily a cardiac output issue with compensation of increased systemic vascular resistance. So you see, so this is where the table gets a little weird because it's like increased or decreased occasionally. It's not helpful. So the systemic vascular resistance decreases, cardiac output is going to increase, right? And we talked about sort of the compensatory component. Initially, the pulmonary capillary wedge pressure is going to be normal or unchanged, and then it's going to drop as you're unable to compensate further. And then because of that, and because of this dilation of systemic vascular resistance, blood is going to flow through, and you're going to have an inadequate extraction of oxygen because there's not going to be enough, the capillary beds are too dilated. So you're going to get more oxygen coming back than you otherwise would, so the SVO2 would be over 65%. Good. We talked about anaphylactic. Septic is another talk in and of itself. Don't forget neurogenic or Addisonian or adrenal shock as well. Okay, so we look at those as well. Anaphylactic, right? Bee stings, penicillin, nuts, poison at the wedding. Basophil and mast cells release histamine and histamine-like substance. So it's this vasodilatation, but it's a different mechanism than with septic shock. You get this difference, arteriolar dilatation and decreased arterial pressure for that reason. Capillary permeability, death can occur quickly. Death is certain, the time is not. The night is dark and full of terrors. Septic shock. So over 750,000 cases of sepsis occur in the U.S., resulting in approximately 200,000 fatalities. So it's an important disease process. The most important thing to remember about septic shock is that infection alone is normal, right? I mean, there's an adaptive response to infection. You have a fever, you have tachycardia, your white count goes up, you're sort of responding to that. That's infection. But the difference between infection and sepsis is that sepsis is a maladaptive response. You get organ dysfunction. So it's some relationship between the infection and the host and the organism that causes this dysfunction, right? And you really sort of get philosophical about it. You think about like penicillin killed bacteria, right? And antibiotics kill bacteria. And we can figure out what bacteria it is, and we know most of them are susceptible to many of our strong antibiotics. Why can't we just give everybody these antibiotics, kill all the bacteria that's inside them, and then cure sepsis, right? We can't, because even if we kill all those bacteria, there's already a process that's ongoing inside. The host sort of has this maladaptive, maybe over response that then injures itself and is perpetuated so that they still die, right? Particularly if you don't kill that infection right away. Neurogenic shock. Sometimes we see that. You'll see it more if like you decide to be an anesthesiologist or something stupid like that. And that's because deep general anesthesia or spinal anesthesia will sometimes cause that, right? But certainly any type of injury to the brain, you will also see that in the neuro ICU. Okay, case number 3. Recovering from hand surgery, a 35-year-old man suddenly develops swelling of his left leg, followed by shortness of breath and loss of consciousness. Type of shock. Perfect. Good. All right, so obstructive shock. So decreased cardiac output because of a mechanical obstruction of flow, but still decreased cardiac output. Body responds compensatory by increasing the systemic vascular resistance. So you can see systemic vascular resistance is the compensation to decrease cardiac output. Again, a little complicated because of this early and late component. The same thing with the wedge pressure. Interestingly, so with PE or tension pneumothorax or acute pulmonary hypertension, you would see where the cardiac output goes down, the systemic vascular goes up. Initially, the wedge pressure is going to be down, and then the mixed venous O2 status over 65%. Tamponade is a little bit different in that all the pressures are somewhat equivalent. Systemic vascular cardiac output goes down, systemic vascular resistance goes up, and pulmonary capillary wedge pressure goes up. Can someone explain to me why these two are different in obstructive shock? Why is it that in PE, your mixed venous O2 status is over 65%, and in pericardial tamponade, it is less than 65%? Does that make any sense?
Yes.
What's that?
The gas.
I mean, I think that mixed venous tissue perfusion is either up or down, and it relates to cardiac output and systemic vascular resistance.
Right? I'm saying like when you have tamponade, you have all 4 chambers down.
So it's still going to, the end result of that is still going to be a reduction in cardiac output, which is what's going to cause the shock.
I think it's the way it's calculated that doesn't actually reflect. Is it as? That's what I remember. I don't remember the exact.
Because this is measured in the right atrium, because it's true central, as opposed to just an IVC line, or SVC line. That's an interesting idea. I ran this by some physiologists I respect, Dr. Reed, Dr. Vinayak, Dr. Santi. None of them can answer this question. So it's a little strange. I don't actually understand why these two things would be different. And I think it might have to do with the fact that there's a common final pathway of shock. So depending upon at what point you measure this, it will be equal. And maybe this is early on. But the idea of where you're measuring it and why, that's an interesting point. I'll have to think about that.
I mean, the tissues will grab more oxygen in one of these states than the other to lead to this difference. We're just not sure why that happens.
Well, why is it that in pericardial tamponade it's listed as low, whereas in PE it's listed as high?
Wouldn't all your blood vessels in both lungs all feel the pressure from the equalizing pressure on your left atrium, left ventricle, right atrium, right ventricle? Whereas obstructive shock, unless it's like a true saddle embolus, you wouldn't necessarily have that. So you could still get gas exchange at the distal sites.
Well, this is venous return.
Yeah.
So this
Also-
is blood from
But
the,
it's before.
But the pericardial tamponade is effectively, that's also, I mean, that kind of presents as obstructive. I mean, as cardiogenic to a component, right? Because it's outflow, it's left outflow obstruction. So like like even there it says cardiac output goes down, which is compatible with like what you see in cardiogenic shock, which has a lower mixed venous gas, right?
correct.
So that's probably why.
But why wouldn't PE, saddle
Because
PE?
PE still have the same cardiac output. It's just an oxygenation thing, right? Because you're still gonna, because PE is gonna be a matter of, what's that? That's dead space?
Yeah, but that's not what the cause of shock is. When a PE gets to the point where it's causing obstructive shock, it's causing obstruction.
But even here, it says that the cardiac output will be
Early. is
early.
okay.
It'll be even.
And that's
Whereas
probably
in
secondary
tamponade, it'll be reduced.
immediately,
Yeah. So maybe that's why.
maybe, but then it should say over 65,
Just tell Dr. Nayak we solved the problem.
over 65 early, right? But I appreciate that. Thank you guys for thinking on that deeply.
You don't have as much time.
Right, well, I don't know, I mean, you, both of these still
sampling
have time, you'll identify it as shock and figure out what it causes, what's that?
Like, who's also studying the time sampling, like sampling this, and like, has that been validated since the 60s, when I'm sure this was like initially done?
That's true, I mean, Vinayak participated in these original studies in the 1960s.
Yeah, right.
All right, so the causes, as we talked about, so one thing to think about is acute valvular failure as well, right? Or acute valvular disease, if there's thrombus or some type of obstruction within the heart itself. All right, so we talked about these, and your treatment, of course, the underlying cause. We recently had a pericardial tamponade that was identified by our fellow. The cards fellow came in and drained at the bedside in the middle of the night. And got like a liter of bloody fluid.
This last week,
Yeah,
I
last
stepped him
week.
up.
Yeah, it was done. He didn't do that well. But, all right, so case 4. So a 25-year-old man is the victim of a mugging. What's that? It's Jon Snow that you guys talking about. Remember he was betrayed?
Yeah.
Yeah, remember? Yeah. I hope I didn't ruin a spoiler for anybody here.
No, I finished it.
Oh, you did, good. Okay, that was one of the good things, actually, that most people finished it. So vital signs are 37, 90 over 60, 125. He's confused, he's moaning, he's got bleeding abdominal wounds, and his trembling cool to touch, not just because he's lying in snow. So this is hypovolemic shock. You like that? You like that, Chef? All right. So different than the other ones, right? So hypovolemic shock, volume down, right? So that's going to cause cardiac output to start to drop. Systemic vascular resistance is going to go up quickly. Now this says with tissue perfusion early versus late. So that's why you would think that the other one works well. Nevertheless, the idea is that you lose volume, right? So your systemic vascular resistance is going to increase and your cardiac output is going to somewhat compensate as well by initially being normal. And then as volume drops, it will go down as well. All right, so what characteristics of Jon Snow's dilemma are most consistent with shock? Definitely D. B.
More of like a.
B is the correct answer, but D is a good one too, right? So confused and cool is not the low blood pressure, right? This is another thing, and not the fact that you're bleeding, although that's important too. Yeah.
So if we go back to the mixed set, for the almost impact, you said it was like early and late.
Yeah.
Is that more to do with the oxygen concentration, like the quantity of hemoglobin that's being lost?
I mean, I think it's a combination. I think my concern with these tables, which is why maybe I'll just delete it and make my own table next time, is that, but it's more fun to talk about this way, is that the early and late component, when you think about late shock, and we'll get into this in the rest of this talk, is really, it's a final common pathway. So in all late shock, you're going to have a reduction, right? Because you're going to lose volume or you're going to lose perfusion and you're going to extract more and more oxygen. So I'm not sure, right? Makes sense that you're losing blood volume, right? So you're
Like
losing
thinking like arterial hemoglobin equation.
and losing sort of circulatory, yeah.
Sorry, okay.
No, I like it. All right, hypovolemic shock. Hemorrhage, trauma, significant diarrhea and vomiting can do it. Burns, right? So 2 things to comment on. Yeah. So first, with regards to trauma, It's not just external hemorrhage. Remember, you can lose a substantial amount of blood into your thigh, into your retroperitoneum without any external appearance, right? Except maybe a little bit of bruising. And then also burns, significant amount of burns. You forget how well your epidermis does. You lose profound amounts of volume from burns. Right? Okay, so common final pathway, i.e. death of dogs. Sorry, Central, that you just imprinted on a puppy yourself. So the idea is that to study shock, you just bleed animals because the final common pathway of shock is the same throughout all. And what they found, Guyton and Hall, is that there's certain amounts of blood that animals can lose and therefore humans can lose before you start to see change. And why is that? Because of compensatory mechanisms, right? So in this case, you've got 1 through 6 with regards to dogs. They're all bled to a certain amount. You see that it all drops with regards to arterial pressure initially, but depending on how much blood volume you've lost, you can compensate to a certain extent and actually recover. 1, 2, and 3 kind of recovered, but 4 through 6, although they recovered transiently over a period of time in minutes, they all succumb, right? So there's compensation, but only to a certain extent. So that leads you to think about the 3 stages of shock. So there's non-progressive or compensated stage, where you basically get this you get this compensatory mechanism that's so strong enough that you can basically recover completely and actually have very little sign. Maybe a little bit of tachycardia, a little bit of low blood pressure that comes back up. Progressive is one that will continue to go unless you start to continue to develop, unless you treat. And then irreversible is a point where you only know in retrospect. And we've seen these patients, right? Where you think you've treated them, you've gotten the blood pressure to come up for a period of time, but then they die. So Johnson is either compensated or progressive. We don't really know until he gets further evaluated. So compensated, I talked about, right? So asymptomatic, up to 10% drop in total blood volume. So you can take 10% of blood out of somebody without having really any side effects. And that's because of all the compensatory mechanisms that exist. Within 30 seconds to 1 minute, you have your sympathetic reflexes. Angiotensin vasopressin mechanism and reverse stress relaxation is 10 minutes to 1 hour. The angiotensin vasopressin we'll get into with regards to renin and angiotensinogen 2. And then restoration of blood volume by absorption. So there's actually absorption out of the tissues within 1 to 48 hours. The compensatory mechanisms you're all familiar with, baroreceptor reflex, that's the sympathetic response. CNS ischemic response happens at lower blood pressures. Reverse stress relaxation, renin-angiotensin system, endogenous vasopressors, and restoration of blood volume. I mentioned a couple of them. And so this is that concept, right? Only 15 to 20% of blood volume can be removed before death without sympathetic reflexes. But with sympathetic reflexes, you can take 10% and have really no change. So the juxtaglomerular apparatus secretes which hormone involved in blood pressure homeostasis? Anyone? Good, excellent, right? And so this is key because the renin secreted converts angiotensinogen to angiotensin 1, then to angiotensin 2, which is a powerful vasoconstrictor and one of the last ones that we were able to commodify for profit. And luckily, we have subsequently done that, and we have therefore become rich beyond our wildest dreams. So all of our endogenous vasoconstrictors, epinephrine, norepinephrine, vasopressin, angiotensin 2, Giapreza, right, are all commercially available.
If you stop it within 48 hours, they refund you.
Is that true?
Yeah.
Say that.
Because there's some segment of people who are non-responders to it,
Uh-huh.
who just it doesn't even like show the distributor or something.
So if you stop Giapreza within 48 hours, they refund your money.
Yeah.
Wow, who knew?
Or like something along those lines. So it's like the first dose.
Yeah, you're either a responder or non-responder.
Let's just think max duration of treatment 47
Yeah,
hours.
well, you got
and
well,
they'll never have
that's
to pay
true.
for it. And then you switch over because they can fix by then.
But now, we don't have it here at Georgetown. We evaluated whether we should get it, but the studies in comparison to the others weren't really that compelling. So I haven't seen it being used that often. I've seen one patient who came over who had been on Giapreza, and she had substantial necrosis of her feet and hands. And that's a side effect of Giapreza as well. But that's a one-time story.
Is the indication like after you've already like added 3 or 4 pressors?
That's right.
Yeah.
Well, a couple.
They started using it at hospitals, like Virginia hospitals a lot, so like, now they put more people on it, but it doesn't, most of the time, it doesn't get much.
Yeah. Did they put it on as like a second, a third?
Sometimes they'll do it if they're trying to, if it's just pure sepsis.
Yeah.
But, other than that, they won't.
And what about side effects?
Side necrosis.
Is that something that was seen more often?
I saw 2 patients with it.
Got it.
At the time that I've been
It's kind of
there. With the necrosis.
yeah. I mean, this person survived, but they lost their fingers. So.
It was available at the city. That's the first one. It was definitely not first one, but you could order it through the system.
Yeah.
And that's where we're getting Hall.
From Mississippi.
Dr. Hall was our professor.
Oh, wow.
Does he like to kill dogs still?
Yeah, they have a lab.
Do still have that dog lab.
A lab
Yeah.
or a science lab?
Yeah, no, I mean, those guys are like the fathers of cardiovascular physiology for that reason. Okay, good. So our 25-year-old mugging victim had a lot of blood loss. Trauma team was activated, got imaging. Right, so this is a sort of a lack, internal lack to his liver, some bleeding within his spleen as well. So the progressive stage of shock is when compensatory mechanisms are maxed out, right? And there's this vicious cycle of progressive cardiovascular deterioration. You can still intervene in progressive shock, and I mean, you should, right? With progressive fluids and vasopressors and treating the underlying cause. And there's a point, as I talked about, between progressive and irreversible that you can only determine in retrospect whether or not you've gotten to that point. But the whole idea of the golden hour is this idea to try and avoid that point where you get to irreversible shock. So I quote in full, there's a golden hour between life and death. If you were critically injured, you have less than 60 minutes to survive. You might not die right then, it may be 3 days or 2 weeks later, but something has happened in your body that is irreparable. And man, we see this, right? I mean, these patients, they come in, they're under profound shock. We do everything we can, we give them critical care. But sometimes, even though we do everything we can, there is they die, even if we get their blood pressure back up and we keep them up for a period of time. So we're concerned about John Snow and the fact that his progressive shock has become irreversible. So this irreversible shock, right? Again, as mentioned, progressive feedback loop with decompensatory mechanisms and an inexorable march towards death. And these decompensatory mechanisms are in shock. It is a progressive feedback loop. Myocardial depression, CNS vasomotor failure, acidosis, thrombosis, tissue ischemia, and increased vascular permeability. And I've left the talk of the types of shock, and now we're just into the sort of final common pathway of bad shock, right? And the fact that there's these compensatories, that there's this feedback loop, and these effects that occur no matter what type of shock was sort of the initial and severe. As an aside, we often see this in hemorrhagic shock, right? Where hemorrhagic shock in patients classically with a GI bleed, so there's going to be a mixed picture there too, potentially with cirrhosis. We give them, they come in with a hemoglobin of 5, they're on pressors. We give them units of blood back, we get their hemoglobin back up. We stop their bleeding by GI coming in and doing like scope, right? But they're still in shock. Right? So what is it about that? Why are they still in shock? Now, sure, there's a little bit of distributed shock, maybe from cirrhosis itself. Of course, they're developing a little bit of renal failure as well. But I think there's also that component of progressive shock that is now irrespective of the initial inciting cause or the initial type of shock, and then you see that continuing. So we see those patients, and many of them are progressive and they recover. Some have developed irreversible shock. We just don't know it yet. Right?
Like factor of reperfusion injury going on.
Absolutely.
Leading to more inflammation, like a reperfusion injury.
Absolutely. I mean, I like the way you're thinking with regards to reperfusion injury. That likely, it's probably very similar to what happens in true reperfusion injury, where somebody's had a crush injury or something, and then there's a reperfusion thereafter. But so this table, I think, is from the good Mississippi doctors, is a good one, right? So you got decreased cardiac output from shock, right? Leads to decreased arterial pressure, decreased systemic blood flow, which then leads to this decreased cardiac nutrition of tissues, some intravascular clotting. The decrease in the nutrition, right? Brain stops working as well. You're not getting the sympathetic reflexes as well. Therefore, you get vasodilation. Vascular system itself, capillary permeability, edema, vasodilation, tissue ischemia. This tissue ischemia itself, the cellular death occurs, releases toxin from the cells, right? Which then leads to vasodilation, venous pooling, decreased venous return, which leads back to decreased cardiac output. At the same time, cardiac depression from release of toxin goes back, decreased cardiac output. So you get this continuous cycle, right? Which is no good. So it leads to these things, right? So acidosis just overall, right? We see this in patients right there, and it's usually lactate buildup, right? Also, impaired kidney function happens, prevents adequate excretion of protons, so you have worsening acidosis from that. Cardiac impairment, in ion channel malfunction, and reduced reactivity to catecholamines. But that's a key point because the pressors are on, they're not working as well, the patients are not responding. You give them 1 amp of bicarb, and all of a sudden their MAP is like 110, right? And that's because of this characteristic. Now, does that 1 amp of bicarb do anything from efficacy standpoint? Absolutely not. But we like to do it every once in a while.
Just every once in a while.
Every once in a while, not often. Thrombosis. So capillary microthrombosis due to stasis. So you've got this substantial venous systemic vascular constriction, right, to try and maintain perfusion. And you get these areas where there's very, very poor perfusion. And when the blood slows and venous stasis, you get microthrombi. And then you get this like microenvironments within those distal capillaries where there's cellular death, toxins, sort of like a reperfusion component, right, where those toxins are released. This tissue ischemia develops as well. So on a micro level, which then perpetuates the shock that's ongoing. And as we talked about vascular permeability, right, so any injury to the vascular walls will cause worsening capillary leak. And then CNS vasomotor failure. So this low flow to the brain's vasomotor center depresses the activity, right, of the brain. And then you get this reduction in sympathetic discharge, sympathetic tone and reduce, which then also reduces cardiac output in SVR. This doesn't usually completely fail until the MAP is less than 30. And that's why when patients are like very close to death and they may be bradycardic and they are profoundly acidotic, you still see a MAP. The MAP doesn't go to 0. The MAP is like 30, 35. That's like just non-cardiac output derived vascular tone. The brain is firing a little bit more until the end. And then only thereafter does the MAP drop. But you'll see the MAP still remains at a number. So in time, de-compensatory positive feedback loop cannot be reversed. So Guyton Hall again, blooded dog, right? Substantially, reduce their cardiac output substantially, right? Then you get this period of time where there's the compensatory mechanism for the dog. The dog is trying to, do all the things the dog's supposed to do. Then you give the blood back, right? You get the blood back, you get that cardiac output all the way back up to 100%. Even though you've been able to do that, the patient still dies, right? So this is the whole example of this progressive irreversible shock. And you don't know that at the time that that's the case. It's only thereafter that you can see that occurred. All right. So although the doctors did everything they could in Westeros, they really needed some alternative medicine for surviving. If this was actually downloaded, you would see his eyes start to open, but unfortunately we've gotten rid of that. So that's my talk. Let me know if you have any questions. Oh, good. Okay, so then one question to you is it time to switch to a different pop cultural reference?
No, that's
Can I milk
yeah.
Thrones for a few
You
more
got
years?
some more miles on that one.
A few more miles on that?
That's a Volvo, baby. That thing's gonna go for a while.
Say that again?
That's like a Volvo. That'll go for a while. So
Right?
yeah.
I think so. Yeah, good, okay.
What was the previous pop culture?
I didn't have one. I didn't have
Oh,
one.
okay.
Yeah. So this popped, this one popped into my head, but I was trying to think of other options. The last one was like variations, like
I
this
see.
person died here, this person died here. This is the only thing I could come up with that like really, because there's only a few shows that are like so many different deaths.
I have a question.
No, please.
So I was reading that apparently cardiogenic shock does have a distributed component to it, like as it progresses on. I don't know, like I've never like heard of that before. I just wondered, like,
I think it's the end stage change. That's like the catch
Final
all basin when any shock gets.
I mean, it's hard for me to say. Is
because
it
it's like an
specific to-
immune cascade, right? Or like an inflammatory cascade. That
Right.
makes you go to
Tissue injury, cytokine.
So I just want to, like, would that change your treatment with biotic or because it's already at stage, not literally matter?
Well, I mean, I think we don't know it's at stage till it's at stage, right? Till it's after that stage, we just keep doing what we're doing. I think we're lucky in that our pressors often have a, peripheral vasoconstriction component as well as ionotropy and a little chronotropy, so the pressors themselves help us with that. But I think if you were to have pure cardiogenic shock and you were on dobutamine alone, then you might think, well, let me do something else. If the increased cardiac output alone is not enough to provide an improvement in the perfusion.
Right.
But I think you're right. I think it is. It's because of this final common pathway, and that's what I think complicates it and makes it very confusing when people are learning about shock. They're like, wait a minute, what's primary? What's compensatory? What's early? What's late? What's happening? Right? Because it's just like everything else. We classify things in a way that makes sense and you can teach it physiologically, but then it gets muddied in clinical practice and as time progresses.